Good morning. This is Gary Greenswag, and thank you everyone for joining us. We have a great morning scheduled to talk about social determinants of health. And I'd like to just start by reminding folks that this is Women's History Month. And I know that there's been celebrations throughout the month and a great Women in Medicine History Month. And congratulations and great to celebrate that. And Doctors Day is coming up. And so you'll hear more about that in the next week or so. And with that, I would like to turn this over to Dr. Sagar, who is the mastermind of this morning's program, along with Rachel and John and the rest of the team, to talk about social determinants of health and how we are migrating into that space. We have a great speaker and panel, and Dr. Sagar is going to do the introductions.
Thank you, Gary. That's very, very kind of you. Thanks, Dr. Greenswag. Good morning, everybody. We are very excited to have you here because we have quite a treat in place because we have Dr. Fiori joining us, who has a significant specialty in this area, and then, of course, Dr. Corey Karlin-Zysman and Dr. Barbara Martin to join us for the panels. Before I get started on the intros, I just wanted to say a big thank you. There have been a lot of people who've been working very, very hard, dedicated, committed across many teams within Common Spirit Health and PE specifically, that we just wanted to say big gratitude to them because a lot of the work that you will see that's forthcoming in the months ahead is really the product of all of their hard work. So just a big kudos to all of them. With that, I have the honor of introducing Dr. Kevin Fiori, who is the Vice Chair for Community Health and Engagement and inaugural Division Chief for the Division of Community and Population Health within the Department of Pediatrics and is the Director of Community Health Worker Institute at Montefiore Einstein and is the Director of Social Terms of Health for Montefiore Health System, Office of Population and Community Health. He is also the Associate Professor in both Pediatrics and Family and Social Medicine at Albert Einstein College of Medicine and co-founder and senior advisor at Integrate Health. His research aims to address health disparities in communities both in the Bronx and abroad, and is a primary investigator on multiple ongoing implementation research studies in West Africa and Bronx, New York, particularly focused on community health worker integration within health systems. Dr. Fiori completed his residency training in social pediatrics and served as chief resident at the Children's Hospital Montefiore. He completed an MD at the University of Washington, his MPH at Boston University School of Public Health as part of a 3-year Peace Corps service in Togo, and a master's in science and clinical research methods at Albert Einstein College of Medicine. Dr. Fiori and his spouse, Jennifer Schechter, were awarded the 2016 Sargent Shriver Award for Distinguished Humanitarian Service by the National Peace Corps Association. So Dr. Fiori is definitely an overachiever by all standards, but over the last couple of months when we have gotten to know him a little closer, I will say he is a treasure trove of wisdom, and we are really looking forward to welcoming you, Dr. Fiori.
Thank you so
Our panelist this
much.
morning, our panelist this morning is Dr. Corey Karlin-Zysman, who serves as the Chief of the Physician Enterprise for Common Spirit Health, providing strategic clinical leadership and oversight to support physicians, advanced practice providers, and clinic teams across the continuum. She's responsible for guiding the PE leadership team, growing diverse provider services, supporting Common Spirit's academic mission, and fostering collaboration with regional and clinical leadership to drive clinical excellence, physician wellness, patient experience, and care coordination. She has over 18 years of progressive leadership experience in large integrated healthcare systems, and Dr. Karlin-Zysman is a results-oriented and collaborative physician leader. She's held several key leadership roles in academic medicine, hospital administration, and large regional medical groups. Prior to her current role, she served as Senior Vice President for PE for Arizona and Nevada, where she played a pivotal role in strengthening clinically integrated networks, expanding the medical education programs, and deepening our partnerships with Creighton School of Medicine in Phoenix. Dr. Barbara Martin is Assistant Senior Vice President for Advanced Practice providing executive leadership and strategic direction for the Office of Advanced Practice. Dr. Martin is a nurse practitioner with clinical and leadership experience in cardiology. She received her PhD in 2020 with a focus on the role of advanced practice providers in systems change work to enhance and improve systems of care delivery. Prior to joining Montefiore Health in 2019, Dr. Martin was appointed Executive Director of the Colorado State Innovation Model Office, leading the state health reform efforts to integrate behavioral and physical health care supported by value-based payments. So, quite the crew this morning. Personally, I am really looking forward to the panel discussion and, of course, the background, Dr. Fiori, that you're going to be sharing. So, with that, I'll yield the floor to you. Welcome and take it away.
Thank you so much. I'm really honored to be here. I'm looking forward to the discussion. I'm going to just provide a brief introduction about what we're doing here in the Bronx at Montefiore Einstein. I want to say at the onset that we have a lot of experience with this, and with that experience comes a lot of we've made a lot of progress, but we've also made a lot of mistakes, and I'm gonna try to bring out some of the things that we've learned at least over the past 8 years that I've been working on this initiative. So with that, I'll start. Give me 1 second. So I'm going to break this talk down into 3 objectives. I want to summarize the current evidence, guidance around health-related social needs screening. This is an ever-changing landscape. We've had accelerated interest in this in the past, especially 3 to 4 years. We're experiencing some changes as we speak, and we can definitely talk about that. I want to draw on what Montefiore has learned as an institution around health-related social needs screening, and then also providing patients with support after that screening. And I want to talk a little bit about future directions, focusing on how do we support patients who come into our practices and tell us, I don't have enough food to eat, I don't have stable housing. What is healthcare's role, and how can we make meaningful impact in that area? So I want to just provide a brief introduction about Montefiore Health System for those that maybe are not familiar. So we are a nonprofit private system located in New York, mostly in Bronx County, New York, Westchester County, and the Lower Hudson Valley. We have 9 hospitals. We are the largest provider of health services in Bronx County, which is also a borough of New York City. And one of the things that is striking when one looks at the health outcomes of communities within New York City is that there is a clear and stark disparities. And if you look, I'm a pediatrician, so I'm a little bit biased. So this is a assessment that the Citizens Community for Children does, and it looks at community risk ranking, with higher risk being in those darker colors. And if you look where the risk is concentrated in New York City, you can really see it in Bronx County. And that matters when it comes to thinking about how one delivers healthcare in that area. And the reason why it matters is that we know that health is driven by more than just healthcare. I'm not suggesting that healthcare is not an essential part of keeping individuals healthy, but the reality is the places where people live, work, worship, go to school, those have huge impacts on health outcomes. It's been estimated upwards of 40 to 80% of a person's overall health is dictated by these factors. And so it's important for us in healthcare to not bury our heads in the sand about this, but to acknowledge that this is going to affect how we practice. And recently, there has been more evidence suggesting that not only does it affect someone's healthcare, but there are things we can actually do about it that will make a difference. So this is a recent piece that was put out by the Social Interventions Research and Evaluation Network, SIREN, which is based at the University of California, San Francisco. It's directed by Laura Gottlieb. She's a tremendous leader in this field. She's a family medicine doc. They describe interventions that have been shown to have impact, sort of 4 pathways. So one, this idea of connecting patients with social services could lead to improved health. The idea of emotional support, healing relationships through connecting patients to social service navigators, health service connection pathways. So the idea that you're making adjustments in care that leads to better access to health services. And lastly, thinking about how one's health plan or management plan may have to change based on the fact that, the patient that you has diabetes also has a food insecurity issue. So making tailored plans around that reality is sort of essential. So SIREN sort of describes these social interventions in these 4 pathways. And in 2019, the National Academies of Sciences, Engineering, and Medicine, they actually came out with what I would say the gold standard is in terms of guidance. And they break it down into sort of 5 A's. So that health systems can do to integrate, social care as they're providing health services. So the 5 A's include things that one can do on an individual level: adjustment, assistance, and I have in this table, examples of what that means, things that can be done on sort of a community level, alignment, advocacy activities. But it really starts in the center of being aware and being aware of someone's social needs. And so I'm going to start the talk by going over what Montefiore as a health system, what we've learned the past decade around 2 of those A's, and that is awareness, and that focuses on health-related social needs screening, and also the idea of when we identify somebody with a problem, what are we doing about it? And that falls into the assistance category. And I'm talking about doing this at scale. So Montefiore, for those that aren't aware, we had one of the first social medicine programs. And so, and our current CEO, Dr. Philip Oswald, he was one of our program leaders in this. And so we have a long-standing history of thinking about asking patients when we see them in our practices, whether it's in the hospital or our outpatient facilities, about these kinds of things. But prior to 2016, we didn't really have a way of systematically asking patients when they came into our health facilities, do you have enough to eat? Do you have stable housing? And so in 2018, we launched our social needs screening and referral initiative. So the idea was we wanted to have a systematic way of assessing whether our patients had these social needs. If they had these social needs, providing resources at the point of care. And lastly, for patients that needed additional resources, having teams of individuals that could support that. So I'm going to go into a little bit more detail about this. So we started with the health-related social needs screener. We debated for over a year, and I'm harping on this because this is one of our key lessons learned, how we were going to get physicians and clinical teams in these busy practices to just do one more thing, add one more thing to their list. So we knew going into this, we had to have a set of questions that were not exhaustive. So a 100-page or 100-question survey was not on the table. And secondly, when somebody asked a question, it had to be easy to interpret. So we tried to avoid things like Likert scales, complex answers, free text. So what we ended up with was adapting the Health Leads screening toolkit. We chose initially 10 questions. The responses were yes and no. And we integrated that within our electronic health record so that the screening would start either on paper or electronically, and then it would get entered into our EHR so that the clinical team could see the result across the health system. Next, we invested in a online social service platform. Initially, it was called NowPal. We switched to another vendor recently called Find Help. And the idea was we wanted to have an updated resource list of, for example, if somebody said I had food insecurity, you could type in, the zip code that the patient lived, and it would give you a list of food pantries around their neighborhood. And then lastly, we invested in teams of community health workers. So these were Bronx individuals who the clinical team could refer to. So we didn't want our MDs and nurses and NPs and PAs, we didn't want them spending lots of time trying to figure out, how can I help you with your SNAP application? We wanted somebody else with expertise in that to do that. And so this was our initiative that we started. I mentioned the screen. I'm not going to go into detail about our changes, but I'm putting this slide up here to say that as a health system, we've spent a lot of time debating and making changes to the screen. I don't know that that was the best use of our time, but we've spent a lot of time as a health system sort of trying to optimize this screen. Here's just some screenshots of the integration of the screen. So as mentioned, we have two ways that it gets into our electronic health record. In most cases and in most practices, it starts on paper. The patient will fill it out in the waiting room. The results get entered as they're being seen and triaged, as part of their vital intake process. There's also the option using a patient portal called MyChart that patients can enter the results of the screen and automatically uploads. One of the nice parts of Epic is that it has what we call this social determinants of health wheel. So it quickly allows anyone on the clinical team to see if you hover over one of these boxes, like I'm hovering over housing in this screenshot, when the patient was last screened and what the result of that screener was. We have worked across our health system in different contexts to standardize the workflow. One of the key lessons that we've learned is that you can't just tell the visit provider, you need to give this screen out, that it really needs to start at the front desk. And you have to divide sort of the tasks. So with front desk and nursing having a major role in making sure the screening gets done and entered, and then the main visit provider assessing the results and then referring as needed. So this is what we've developed over, since starting in 2018. We're making fine-tuned refinements all the time, at least trying to. And next, I want to go to what are some of the results? What are we seeing in the data? So I mentioned all of this data gets stored into Epic. And as a health services researcher, this is sort of like a dream because we have lots of data on lots of patients. So to date, as a health system, we've screened over 300,000 unique patients. And most of the screening we've actually done in the past 2 years. So last year alone, we screened about 175,000 patients, which was almost a 70% increase from the year prior. Because we have this data stored in our EHR, it gives us quick ideas about what are the needs that our patients are telling us that they have. So, of the 3,700 patients that have 37,000 patients rather that have told us about social needs, food insecurity, housing quality, housing insecurity, those have been our top 3 needs. And so it allows us to plan in terms of when we have resources. For example, if we have, if we're going to plan a food drive, the community-based team, community affairs team rather, will contact my team. We'll look at the practices that have sort of the highest risk or highest social need, food insecurity, social need prevalences, and we'll plan for have the food drive in those locations. So it helps us tailor our interventions. It also tells us a lot about how social needs are affecting our patients. So this was an assessment we did. It was over 40,000 adult patients in the primary care network. And what we wanted to ask was, if we looked at patients who had social needs versus those that didn't, was there any difference in missed appointments? And no-show rates are a big issue in our health system, as I'm sure they are in your health systems. It means that the patient didn't get care. It means that we lost money. There's a fixed cost when the provider can't see the patient. We have a very hard time like getting somebody else into that slot. And it also means that somebody else didn't get care. So when we looked at this data, what we saw was patients that had social needs, they missed more appointments. That difference actually represented about 176,000 no-show appointments over the course of 18 months. And what we also saw is that we handed that number over to our finance folks and said, give us a back of the envelope calculation. Well, what did that cost our health system? And it was about $18 million in lost revenue. So it started to give us a sense of, well, what does this really mean in practice when we're seeing these patients who have these social needs? And the other question is like, what can we do about it? So turning to costs, we did a similar assessment to try to figure out, well, to patients with social needs, are they costing our health system more money? And when I say costs, I mean in terms of, we have an internal way of assessing our internal annual cost per patient per episode. And so what we saw again was a patient with a social need compared to somebody who did not, and controlling for different covariables, things like race, ethnicity, age. We still see that patients with social needs cost it on an annual basis about $1,700 more than patients without social needs. So then we started getting down into, well, let's think about like how we're doing in terms of, are we, we provided all these tools, we built all these tools to screen. Our practices really using them. And one thing that we saw, so this represents, when you see a C1, C2, that is a clinic 1, clinic 2. These are the 18 practices in our primary care network based in the Bronx. And the percentage is how many of the active patients that were seen in the last 18 months in your practice actually got one social needs screener. And our recommendation for the teams was, you need to screen at least once a year. That's our goal. And what is very apparent by this figure is that there is a lot of heterogeneity over who's actually using the tool and who's not using the tool. And you saw, like, and I'll brag a little about the pediatric practices, it did a little bit higher than some of the internal medicine. But what it told us as a health system is that it's not enough just to provide folks with a screener and integrate it into the EHR and that they're just going to use it. That we really needed to be a lot more deliberate about, well, what are the factors that lead to places screening more? And so we did a study to try to figure out what are those factors. And a couple things really stood out. One was when we integrated the screener into MyChart, our patient portal, we actually saw a huge increase in screening. The second thing we learned was when you had a chair of a department, and in this case, we had the chair of obstetrics and gynecology say, this is going to be an initiative of the department. This is going to be a goal of the department to screen every OB patient that comes into one of our practices. Screening goes up. And lastly, we expanded our CHW program, and I'm going to talk about that a little bit more in a second. And that had a very significant increase in impact. And we did a qualitative study to follow that up. And it was and this will not be surprising to any of the providers on the call, but providers we found are not resistant to screening. They think it's important for the most part. However, what they don't want to do is they don't want to be in a position where if somebody comes in and says, I'm about to be evicted because I prompted the question with the screener, they're not going to have anything to do. And so they need a partner, and they need a resource, and they need a solution. And we found when we introduced highly optimized CHWs into practices, that provided a lot of confidence for the clinical teams to then go ahead and, screen on a more universal basis. And the last thing that we found was when we could identify an NP, an MD, a nurse, somebody in the practice who could serve as a provider champion for both screening and navigation, we would see huge increases in screening. And this is the study that we did, and again, showing my bias, in the pediatric practices. I'm sure this happened in internal medicine and family medicine as well. We didn't do that study. But we saw a huge increase when we had provider champions into the practices. So now I'm gonna sort of end with, well, how do we really support patients once we find out that they have food insecurity, that we find out that, they have these needs that we were not trained to really address in medical school or in residencies. So one of the things that Montefiore has invested in, and I, as Dr. Sagar mentioned, I have been working with community health workers for a long time, mostly outside of the US, over 20 years outside the US. So I've sort of drank the CHW Kool-Aid. I'm just going to disclose that bias. But we have found here domestically in the Bronx that is a very effective strategy. And it's such an effective strategy that we've invested in a centralized structure called the Community Health Worker Institute. The idea is we want to optimize community health workers integration, and we see it as a way to provide very talented people that live in our community, Bronx-based households, with an opportunity to get involved in the healthcare system in terms of employment. We spend a lot of time for that reason in our professional development. We partner with a local community college. So a lot of training, a lot of mentorship. This is often somebody's first job. So they have lots of community expertise and shared lived experience with our patients, but they need a lot of coaching around, well, how do you navigate these health systems and these different practices? And so we've set up a structure to provide that professional development. We know that community health workers are often in the fast changing landscape of social needs services and resources. They're often the best resource of what's new. And so we actually developed an internal intranet where the CHWs can share amongst each other at the different practices, what's new, here's a new housing resource. We want to make it clear to the clinical team, to the person who referred to a CHW, what happened with their patients. And this is a really important point that I just want to underline, that, and I have this as well with the families that I get to work with in my clinical practice. We have a very, strong relationships, therapeutic relationships. And when you refer out to somebody else, you want to make sure that they're doing good by your standards. And so we made a point to make sure that the CHWs provide notes, timely notes back to the clinical team, so that they knew and understood what happened when they sent that patient out who had a housing issue. And lastly, we want to understand the data in terms of optimization. So we look at two measures when we refer patients to CHWs. One, did they actually get the service? We call that status of service. So if we sent them to a food pantry, did they actually go there? And then we ask the second question, which is status of need. So we sent you to the food pantry. Do you think we've made progress as a result of that? So we look at those measures over time and look for ways to optimize them. So to date, just to give you kind of an overview, so the CHW Institute actually started in June of 2022. We supported about 9,400 families. That generates about 40,000 encounters. So a patient will meet with the CHW, and then the CHW say, I'm going to call you in 2 weeks, or we're going to have a follow-up visit in 2 weeks and talk more about this. And then you can look at sort of our service received rates and percentage of patients reporting progress on social need. We're using what's happening in our health system to learn. And I mentioned this sort of earlier. Phase 1, we looked at patients that had social needs and those that didn't have social needs, and how that affected things like missed appointments, how that affected things like costs. As we've introduced HWs, we're doing the same thing. And so we're actually just completing a cohort study that's looking at, if you expose a family to a CHW, do you see a reduction in missed appointments? And in pediatrics, we actually do. We see a 20% reduction so far. So we're leveraging the fact that we're never going to do a randomized controlled trial on this, but we want to learn as much as we can from what's happening naturally within our health system. And we're trying to disseminate what we're learning. This is the recent paper that it summarizes a lot of what we've talked about. So in closing, I just want to sort of highlight some of the key lessons that we've learned. And I want to make it clear, like, we have not figured this out completely. We've made a lot of progress. I think we have a long ways to go. So the first point I want to make, and I hope you saw that by the 4 different versions of our screening tool, I would, as you're thinking about introducing screening or maintaining screening, really de-emphasize that search for that perfect tool. I don't know that it exists. I think CMS has weighed in now, and they have a tool, screening tool that they recommend. I'd use that one. Focusing on team buy-in is critical. None of this gets done, like most of our health systems, none of this gets done without nursing. They are a key factor in the screening getting completed, the data getting into the EHR, and the families feeling comfortable about sharing that data. So they're key partners in this initiative. I alluded to this, but I would just say that plan for substantial ongoing EHR investments. Every time we want to make a change or we want to do something new, it sounds simple to just make that change in our EHR. It never is, and that may be just a factor of our EHR, but I think it's probably widespread. And then lastly, if you're going to focus, if your teams are going to focus on something, I would focus a lot on, well, what do you do when that patient identifies a social need, and having a plan and having workflows for that. So with that, I'll stop. I know I went a little bit over time. I apologize for that, but thank you very much for the opportunity to share, and I'm looking forward to the discussion.
Well, thank you, Dr. Fiori. That was great. Exactly what we were hoping for. I think you've teed up the panel discussion very well. We're having side chats here because we're like, oh, we want to ask about this and then about this. I guess I can start off, and then Gary, I'll hand it off to you. Just for all the 3 panelists, right? What comes to mind as I'm hearing Dr. Fiori talk is it needs to be a system-based approach as opposed to an individual practice, an individual physician or APP doing this on their own. So to me, my question is, what does success look like when we think about a systems-based approach for social determinants of health screening? And then I guess I'll go to Dr. Karlin-Zysman, Dr. Martin, and then Dr. Fiori. You can chime in at the top.
Okay, thanks so much. Firstly, just wow, just incredible what you guys have done, the innovation you've done in that space, the evidence you've not just used but then contributed to push this to that next place. I first want to just say this is so important. This is so important. This screening is so in line, so hand in hand with Common Spirits Health mission, vision, values, as we strive to just achieve excellent patient-centered care. So we do have to figure this out. I also acknowledge when I think about things that I lose sleep at night is what you tackled. The disproportionate amount of these amazing things that fall on the shoulders of the few, our primary care physicians. And it's no joke what we're seeing as far as wellness and burnout, and feeling like that this is not what I signed up to do. This is not what I went to med school for. I'm not, there's that fire in the belly is not there. And I love sort of, you gave some great examples, and I think we should talk through more how you got them there. Because one of the things I'd want to know is my gut is you had to take something else off. We can't just keep adding on. How did you prioritize this to get it there? And I love how you engage leadership and IT and team. It's not just on you, it's on the team and all those things. Where was I going with this? I guess I think to your point, Ankita, we gotta like avoid pockets of success. I have no problem with like pilots just to work through the details. Kevin, you spoke a lot about trial and error, and this doesn't just happen magically overnight. But I see Umar on. I see our IT people on. You mentioned Epic. Some of us are on Epic, but we're on different versions of Epic. Some of us aren't on Epic at all. We're on other things. We are heading in that direction. So for me, sort of thinking through, I think without some sort of IT solution, I think this is going to be a challenge for us. So I actually think great minds are going to need to come together to figure out what are those few things we could do to start, but across to start to show some movement. But I'll pass the baton, but those are some initial thoughts.
Dr. Karlin-Zysman, I think if I were to back one of your questions, it would be how do we reinforce a system approach while supporting our teams, especially our frontline physicians in advanced practice, nursing, MA teams in primary care. So Dr. Fiori, if you have any, I have a great question about CHWs, but I think this is such a pivotal question. We'll probably all be hearing from our clinicians in about 15 minutes. How do we do this right? Without taking, or do we have to take something away? How do we really embed this as we're stacking more in our annual wellness visit, et cetera? I'd love your thoughts.
Yeah, you both identified sort of this, that when I showed that graph with the different utilization, I mean, so I think that building out the workflows with the clinical team is crucial. So when we tried at the very beginning to just sort of say, this is what we think is best going to happen, and this cookie cutter approach is going to work across all of your practices, so figure it out. That was not very successful. So rather what was successful is we let the practices experiment a little bit with how to introduce this. And that meant cutting up the workflow and delimiting it, each of those tasks to different parts of the team. And I think when we did that a lot, you could see it in some of the clinical teams, especially some of those. We had a couple that were, of course, will remain not anonymous, but they were really against this idea. They were not against the idea of this is important, but there's just no way we can pull this off. But when we saw that we had IT solutions that would make it more straightforward, for example, and quicker, and then we actually did something where we timed how long it took for a nurse to input the values. And it was about like 37 seconds. So we brought data with us to sort of try to address some of those. And then a lot of the academic practices, they wanted to use this as sort of like a QI or a performance improvement initiative. And that got a lot of interest in a lot of different providers. So that would be another sort of technique. But again, I think at the end, it comes down to you have to have a good answer to the question, if somebody has a problem, what do I do? And it can't be, well, you got to figure it out. Like that's a non-starter. And sometimes it can't be, I'm going to hand them a piece of paper either. So thinking through at the beginning, do you have staff members that can help? Do you have a way to take, what's available? Find Help actually is available throughout the nation. And so but you have to do that with the teams, I guess would be what we learned.
Kevin, can I add on to that? So true. I think, right, one of the you sort of said it. I asked the question, I got a response that I don't have an obvious solution for. So I think what you said was key. High level. We talk finance just a little bit. Some things caught my attention that I think are just key elements to success. And the evidence you shared. You know, the IT build. The online social platform, which I'd actually love to hear more about, which tells you what community resources exist and how to connect them, I believe. Community health workers, all these things. How do we make the math work? Because it doesn't, when we think about the bills we drop and the revenue we see, and that this probably, the extension of the visit and things like that. How did you convince your leadership? How did you get the mathing, basically?
I don't know that I totally convinced them. I'm convinced. So, and what I mean by that is some of what we did at the beginning, we had to find grants for just to pilot it because it was a risk, right? It was, what was our health system willing to take a chance on $1 million of community health workers? But one thing we did is with all of our innovation projects, we had measures and metrics behind it. So we could go to our leadership afterwards, and that's essentially what we did. We went to our chief medical officer and said, look, we have found $3 million in grant funding. These are the amount of families that we've been able to help. This is what cost reduction we estimate. This is the time that social workers were not working with the families, that they could focus on doing mental health counseling, for example. And then lastly, we're fortunate in New York State, they introduced CHW billing in 2024. So there's a reimbursement option for New York State Medicaid, and we have a Medicare option as well. And so bringing all those things together, we approach budget neutrality for our workforce, but it does, to your point, at the beginning, we needed some grant funding. Our health system there were not loads of money lying around to try something new, but we tailored those innovations with data and measurement so that we could show, I talked about some of this, patients with social needs are costing us more money.
Yep.
And that's when we control for other things. And so, what are sort of the more cost-effective strategies?
Right. This is Gary, and would you say that it's also the payer methodology? So it's one thing if you're fee-for-service Medicaid, it's another thing if you're capitated and you can take those dollars and spend them any way you like. And it seems to me that this model works well when you're capped and you can be more discriminating in terms of how you spend your dollars.
Yeah, I would totally agree, Gary. That's a great point.
The other question that I wanted to ask is there specialization amongst the community health workers? So I think I mentioned that I was at Montefiore maybe 8-10 years ago, and I remember having it explained to me like, if someone needs transportation, we call the transportation desk or the food desk or the housing desk. And because for community health workers to sort of have that repertoire of regulation and housing and where you can get this and that. So do you segment the work or have people who specialize in those areas?
Great question. We actually don't. And this gets to we spend a lot of time on the professional development and training and retraining and having a intranet so that if housing regulations change, we do have for housing, there's a housing at risk program that handle more complex cases. So we do have that at our disposal. The only time we specialize with CHWs is there are a handful of CHWs within our institute that focus on only one population. So we have CHWs, for example, in our Healthy Steps program, which is a program that focuses on families with a child 0 to 5 that have elevated adverse childhood experience scores, either on the parent side or the child side. And they do a little bit more in terms of navigation. We also have CHWs at our Lupus Institute and our Montefiore Einstein Comprehensive Cancer Center. And so those CHWs do a little bit more in addition to social needs navigation, but we want all of our CHWs to be able to handle all of that. And then we have a supervision structure that allows for, to your point, if there's a really complicated case, let's get social work involved, or let's get one of our supervisor who knows, housing involved.
Okay.
Yeah.
Great. Okay, it looks like you've got some questions.
Yes, the chat has been active, as has been the Q&A. So I will start with the Q&A because there's a couple of questions more on the detail side. So Dr. Fiori, if you could help us out. One of the questions that's come in is within the EHR, specifically, let's say EPIC, how easy is it to actually get this data when it comes to based on social needs or based on payer? Can we stratify the data across the board? Or is this something that you created especially for your program?
I try to avoid using the word relatively easy with Epic, but it actually, getting the data out is relatively easy. So I'll give you an example. What we do now is every month we get a report of every single screening encounter across the health system. And then we also, in addition with the screening encounter, we get things like, give me their insurance status, their current insurance, race, ethnicity, other demographic variables. And so that is relatively easy getting it out. It's then putting it into a form that is easy to use that is a little bit harder. So we've done dashboarding in something called Tableau. That took some time.
Got it. Yeah, because raw data is raw data.
Raw data
make it meaningful. Right.
Exactly.
Agreed. Awesome. So I think I'll actually ask this of all the panelists. We talk a lot about AI and how does AI, I will say augmented intelligence, the work that our clinical teams do. Dr. Fiori, starting with you, have you guys used any form of augmented intelligence, whether even scribing in the chart to help with some of this?
We're piloting that right now. So it's a little early to say how useful it's going to be, but especially around the documentation. There are different vendors who have approached us on the navigation piece in the sense that they've set up ways that a patient can interact directly with a chatbot, for example. We've done a little preliminary qualitative studies with families. They're not super excited about that, just because, a lot of these needs are very personal, and they feel, they've told me they just feel it's a little awkward sharing that with a computer. So that's as far as we've gotten. But I think there is potential there, but we're just sort of at the beginning of that.
Yeah. And then if I can pull in Dr. Martin and Dr. Karlin-Zysman, I know that we've thrown around the idea of like, when do we use it? When would it be appropriate? So thoughts on SDOH specifically, do you feel there's an aspect in which we potentially tie with this? And I'm recognizing we have a lot of informatics leader on
it's dangerous territory to answer.
Okay, let me make it less dangerous. Dream, aspirational state.
I appreciate, Dr. Fiori, your answer, because the one question I think that is so important that you do ask is, are you interested in help, or do you want us to reach out to you about your answers to the screener? And I can't imagine, there's a human touch, and then the value and investment you've made in the community health workers that are from the community, that are serving their community members in this way. I think there is a component that AI can't replace, but hopefully there are some efficiencies. I'll leave it at that.
Yeah, well said. I don't have much more to say, but what I just think back to the earlier conversation of, again, as we add more and more onto the shoulders of the few, yeah, and they're all important and they all contribute to the health of the patient. I think that is one of the tools in the toolkit that we have to explore. I think to your point, Kevin, and figure out for sure. And maybe it's not in that obvious way with the engagement of the patient, but it's on the back end, the documentation, and then how you sort of connect to the resources and things like that. So I think there's sort of other ways we could use it where still we're not sort of getting, you got to know your audience, right? And I think some people like, oh, an app, I'm gonna fill it out. I think about Notable, I'm excited to fill it out. And there's that crew that's just not gonna, for so many reasons. But I think there's other ways we could use it as well. And I don't see not using it for this and so many other things. So I'm excited at the prospect. We're gonna take a few steps back before we go a few steps forward, but I mean, it has to be part of the arsenal, no question.
There's a couple of other questions, and I recognize we're at time. So I will make sure that the questions from the chat, we are able to email those folks back. There was a question whether this session was recorded and will be shared the recording. Absolutely, it will be made available to everybody. And before I sort of close out, Gary, any last thoughts from you? Can't hear you.
Thank you. This has just been spectacular, and I think the interest is high. There's a note from Elizabeth Miller right at 7:52 a.m. Elizabeth leads a lot of our ministry, Montefiore Health Mission Ministry grant funding, and I know that they have funded a lot of this work. And her comment was, Common Spirit has experience with integration of community health workers in ambulatory care in North Dakota, Nebraska, Kentucky, and Washington. And there is a roadmap model that aligns with the work that Dr. Fiori brought up. And so I do think that this is a worthwhile topic, and I know from reviewing grants with the Mission Ministry Fund that they are exactly this kind of work. And so I think as people are thinking about it, we'll get you connected with Elizabeth. But in all, this has just been a great morning. We'll have it on YouTube and our internal channels, and get lots of
Great.
listen. So thank you so much, Dr. Fiori and Dr. Martin and Dr. Karlin-Zysman and John and Rachel for planning this, and Dr. Sagar as our mastermind of the whole social determinants of health project. Thank you. So Ankita, I'm going to leave the last word to you.
Thank you, Gary. I will echo your thank you. I think this is just the start of a dialogue for us at Common Spirit, and when we think about our ambulatory footprint. But I will also say, I'll make a plug, and I can't not say this because Rachel Bates, who is our system director, and myself, as well as our Lloyd Dean Health Institute, so Dr. Jackson and Dr. Teresa Hernandez, we're putting together a learning collaborative. So if you want to learn more, you want to partner with us, please reach out. We still have spots open, and that will be launching very, very soon, come May of this year. So a lot of the principles that Dr. Fiori spoke about and Dr. Karlin-Zysman and Dr. Martin mentioned, we will be covering in further detail. So thank you, everybody. Have a great rest of your Friday.
Thank you.